Good evening, everyone. Thank you for joining us tonight for the Dermatology Medical Update part of Chris O'Brien Lifehouse CPD series. My name is Lydia Koenig. I'm a CPD Program Officer here at Central and Eastern Sydney PHN, and also working with us tonight, both a Harvey CPD and Events Manager. Before we begin, I would like to start by acknowledging the traditional custodians and sovereign people of the land across which we work and meet tonight. I recognise the continuing connection to land, water and community and pay respect to elders past, present and emerging. I'd also like to extend that respect to Aboriginal and Torres Strait Islander colleagues joining us tonight. And with this, I would like to invite our facilitator for tonight, Dr. Edmund Lee, member of GP Education Advisory Committee for Inner West region. Thank you, Edmund.
Thank you, Lydia. Well, good evening and welcome to tonight's webinar on dermatology. I was told that we have 109 registered for tonight's webinar, which is a record for the Chris O'Brien CPD series. So the reason for the big turnout is because we are fortunate to have an expert panel of 6 dermatologists, all from Sydney Skin Newtown, to be our speakers. So I think that's a bit of a record too. So 6 speakers in one webinar. So that's great. Now, because we have 6 speakers, we will have extended our session to 9 p.m. But I'm sure you will agree that it would be worth your time. So we will keep our questions until the end of all presentations. So please type them into the Q&A and we will cover as many as possible at the end. I will now give a brief introduction of all the speakers and the topic for tonight. So our first speaker is Dr. Andrew Ming. Andrew is a pediatrician and also an adult and pediatric dermatologist. He has trained and practiced in Australia, England, and the USA. Dr. Ming has had a number of articles published in peer-reviewed journals, both locally and internationally, and is regularly involved in training sessions with medical students, GPs, and dermatology trainees. He also presents at medical conferences in Australia and overseas. Dr. Ming is a visiting medical officer at the Children's Hospital at Westmead, where he runs a weekly pediatric dermatology outpatients clinic. His topic for tonight is tips and tricks for the management of eczema. The next speaker is Dr. Nita Agar. Nita completed her MBBS honors and PhD in skin cancer from the University of Sydney. She then completed a fellowship in cutaneous lymphoma at St. John's Institute of Dermatology, which is a tertiary dermatology hospital for the United Kingdom. She stayed on as a consultant at St. John's and was the lead of their non-melanoma skin cancer unit. Since returning to Australia, she has been a staff specialist at Royal Prince Alfred Hospital, as well as working at Sydney Skin privately. Her special expertise is cutaneous lymphomas, but she sees all general dermatology. Her topic tonight is rosacea. The next speaker is Dr. Nicholas Stewart. Nicholas is a general dermatologist with a special interest in skin cancer management and Mohs micrographic surgery. He works at Sydney Skin, the Skin Hospital at Darlinghurst, Westmead, and also Double. His topic tonight is update on injectables and biologics. The next speaker is Dr. Andrew Chen. Andrew worked as a GP prior to training as a dermatologist. He has completed a PhD on skin cancer prevention. He is a staff specialist at Royal Prince Alfred Hospital and a clinical senior lecturer at the University of Sydney. He has consulting rooms in Eastwood and Newtown. His topic tonight is scalp conditions and hair loss. Our next speaker is Associate Professor Li-Chuen Wong. Li-Chuen is a consultant dermatologist specializing in both adult and pediatric dermatology. She was awarded Young International Dermatologist of the Year at the World Congress of Dermatology in 2008. She completed her Masters of Medicine in the immunogenetics of atopic dermatitis at the University of Sydney in 2002. She is a senior specialist, visiting medical officer, and head of the dermatology department at Children's Hospital at Westmead. She was previously the chair, the New South Wales faculty of the Australasian College of Dermatologists and director of training. She is passionate about education and the teaching of dermatology to medical students, general practitioners, and dermatology trainees. Her topic is hemangiomas of infancy and other neonatal conditions. Our last speaker for tonight is Associate Professor Deshan Sebaratnam. Deshan is a staff specialist at Liverpool Hospital. He leads in pediatric dermatology as well as the vascular anomalies and general dermatology MDTs. This year, he was awarded a scholarship from the Ministry of Health to complete a study integrating genomics into healthcare. His topic is genetic skin conditions. So I think we'll start with our first speaker, please. So it's Dr. Andrew Ming. Thank you, Andrew.
Thank you very much. I'll just share, hopefully, my presentation. And now just checking thumbs up if it's gone to full screen.
Thank you.
Yeah, thank you. Okay. Thank you very much tonight for inviting us to talk. And 15 minutes is just going to be a bit of a whirlwind to try to cover eczema tips and tricks. What I thought I'd narrow it down to is parental questions and answers that I often get. A disclaimer is that I guess these are my personal views and from my own experience, and that anything I say doesn't necessarily represent the organizations I work for, but that's how we all practice medicine, isn't it? We have our own experience and our own ways of dealing with things. Now, I imagine the audience here tonight, there's a range. I don't know everyone who's there as attendees, but there's a range of people with decades of experience to even just a few years. So hopefully this will be very helpful for all of you. I didn't want to just talk about eczema because that is covered elsewhere and can be covered at another time, but just little tips and tricks. And one of the things that is challenging is answering parents' questions, because eczema is not a condition where you can simply write a script and just dish it out to the parent and say, look, just use these creams and let's see how it goes. Because there's lots of questions involved and there's a lot of misinformation out there. So hopefully I can address some of the top things that I see during the week. So the first thing I get from parents is, presenting with a baby with eczema is, and I'm talking predominantly about pediatric eczema here, is the eczema started when I changed my diet. I took I had some seafood the night before and the next day they flared, or I had some scrambled eggs for breakfast and a week later the eczema appeared. I weaned to formula feeds. I stopped breastfeeding and I changed to formula feeds. I started them solids. They had a vaccination. They began teething. They had an infection. There's all these different things. And let's face it, there's a lot of things that happen in the early childhood period. And that includes weaning. That includes starting solids. That includes teething. So it's part of our human brain to want to link something that starts with something that's happened. And we naturally do that. And so when eczema appears for the first time, parents think, oh, well, what has happened recently that has changed? And they try to make that association. And that's why parents often come with this link that they think has triggered the eczema. So early or infantile onset eczema is the most common type that we see. The onset occurs in 45% of eczema, it's under 6 months of age. And it usually forebodes a more severe disease. So by the age of 1, 60% of eczemas have presented. By the age of 5 years, 85% of eczema have presented. So we do see teenagers and adults who come with eczema for the first time, but the vast majority of eczema that we see occurs under the age of 1 year. So what happens at the age of 1 year? All those things that I've mentioned above. So that's what we come with, and we're dealing with these preconceived ideas that parents have of what is causing the eczema. So we're already battling that. And so half of children who have onset under the age of 2 years develop IgE-specific antibodies. So of course, at the same time, they don't want to use creams. They're sick of using creams. They see creams as something that is a short-term fix or a band-aid fix. They want to find the root cause of my baby's eczema. So generally speaking, they're looking to find something that has triggered the eczema, and they want you to find the answer. Generally speaking, my experience is their thought is, I think it's an allergy. I think it's something I've given the child, either a solid or it's something that I'm taking myself, and that's causing the eczema. That's the general approach that I feel that parents are coming to. Or if it's not allergy, it's something in the gut or something else that's triggering it that's causing the eczema. However, eczema is much more complicated than simply allergy causing eczema. I don't usually hit them with this table, but you can see from that chart that you can see that there's a barrier dysfunction, there's an immune imbalance, there's a neuroimmune interaction, and there's also an altered skin microbiome. So it's far more complicated than saying allergy causes eczema. In fact, allergy doesn't cause eczema. Allergy is, amongst other things, numerous triggers, including environmental causes and bacterial causes that trigger eczema, but it is not the cause of eczema. And in most cases, it's not simply a trigger for the eczema either. But I want to be clear, and I try to talk about the confusing interaction between the barrier dysfunction and the immune dysregulation and the so-called itch-scratch cycle that develops with eczema, as opposed to just saying, look, we need to do testing to find the cause of the baby's eczema. Because in most cases, skin prick testing is usually not very helpful. It might find any comorbidity in terms of food allergies, but generally it's not helpful for managing a patient's eczema. So I try to move away from allergy being the cause, because otherwise it becomes an unnecessary focus. So something else that we get told is that, oh look, I've been told not to use steroid creams for more than a week, okay? So parents often read the medication insert that comes with the packet, or they hear from other sources that steroid creams used for a week is not the thing to do. What I explain to parents is that often these medication inserts have to have this disclaimer in there, because in many countries overseas, you don't need a prescription for potent topical steroids. So the pharmaceutical companies need to make a disclaimer to say, do not use for a week, because they don't know if patients are using this to treat a skin cancer or scabies or something else. So they need to use this precaution saying, look, don't use for a week, because if it's not working, then you need to seek medical assistance. Often advice is given from pharmacists to not use it for a week. And often pharmacists, when I speak to pharmacists, they say that that's often in their training, that they tell parents not to use this for more than a week. Then you also get variations of doctors giving advice of using 5 days on, 2 days off, or sometimes 10 days on or 4 days off. There's nothing wrong with that, but it's a convenient way of telling parents, look, just use it for a few days and have a few days break. The problem is that parents then worry that if they use it for 6 days and they use it for longer than necessary, that they're doing something wrong. Or when they use it for 10 days on and 4 days off, but it flares within 2 days, then they wait for another 2 days to get that 4 days off, and the eczema gets worse and worse. So my preference is I prefer to treat until the skin is completely clear, and at the first sign of recurrence to restart the eczema treatment. I often use a bushfire or a fire analogy, that you need to put out a fire, and if you put out a fire 50%, it merely flares back up again. So you need to keep putting the water on the fire until it's out, and it's much easier to control a fire once it restarts as a small fire to put it out earlier on. So I want to point to this graph, which is a bit confusing, but if you look at the y-axis as a flare of eczema, let's just say the eczema flares and you treat it. What most parents do is they treat until it's better. They don't treat until it's completely clear. They treat until the flare has gone down, but that still means there's a bit of eczema there. So what happens is they treat and then they maintain with just using moisturizers as they've been told to do, but it flares again and then they treat again, and they get this up and down seesawing effect, and they never really clear the eczema. And so that's why parents get frustrated, because they never really feel like the treatment's getting the eczema under control. So what happens if you do the 10 days on, 4 days off approach? So once again, the skin flares, you treat it, it goes down and might even clear it. But then during the maintenance phase of the 4 days off, it flares again, and then you start treating it, it gets better again, but not quite as well, you maintain. And so you're not completely putting out the fire. My approach, and I'm sure my colleagues are very similar, is that you treat until the skin is completely clear, you maintain, but it flares again. You then try to treat it again. It goes back down, but our general pattern is if you treat it early, the maintenance periods get longer and longer, and you get the gaps bigger and bigger where the skin is well maintained, and you treat early. And we're not, remember, eczema is a chronic condition. We're not trying to cure it. We can't cure it. But if we keep it under control and treat it early, then we have better success of getting it under control. And in the end, I try to encourage parents that, in fact, you're actually using less steroids by this approach than if you're doing this seesaw approach and you're not really getting it under control. So something else that we get told is, but we're told not to apply steroids on broken skin. So there is a truth to that, because topical steroids can impair wound healing and it can increase the risk of infection. However, eczema is broken skin, and so the benefits far outweigh the risks. If you treat the eczema, you in fact get the skin to heal faster, and a healed skin is a barrier against infection. So here's an example of one of my patients who posted on her own Instagram account, whereby using a moderately potent topical steroid, I'll try not to use drug names because I have no conflict of interest there, but using a moderately potent topical steroid, within the next day, it clears, and by that afternoon, it's cleared. So we can get it under control, and it looks infected, but in fact, they didn't use any antibiotics. It was just inflamed eczema. And so you can get it under control quite quickly if you use it on broken skin. I'm worried about the white patches the steroid creams have caused. So parents often mistake hypopigmentation with skin atrophy. That's the first thing. They think that they've read that steroids thin the skin, and they think hypopigmentation is thin skin. So I try to clarify that it is lightening of the skin and not skin atrophy per se. Hypopigmentation is post-inflammatory from the eczema. So it's not the steroid creams that have caused this, but the eczema itself. So once again, if you use the bushfire analogy, you've put out the flames, but you see all the burnt trees behind. It is not the water that's caused the burnt trees. It is you putting out the fire, and you can see the burnt trees. So the parents are concerned about this being scarring. I reassure them that the pigmentation will recover over time. It's often mistaken for fungal infections as well, such as pityriasis versicolor. So I often see patients who actually have resolved eczema, then being treated as a fungal infection, or parents are concerned that there has been a misdiagnosis and the white patches that are still a little bit scaly is in fact a fungal infection, not eczema, but I reassure them. And these are examples of white patches in the cubital fossa. You can see the child on the top right, whereby he has well demarcated patches of white skin, but this was post-inflammatory hypopigmentation. Also the blotchy edges on the patient on the bottom right of post-inflammatory hypopigmentation. Okay, so I'm going to finish off with this last one, which is controversial. And during question times, I'm sure I'll be shot down about this, and I'm going to invite my colleagues to get their opinion too, to see if we're all on the same page. But this is the big one that I'm sure you're faced with, and I can't not address it, is I'm concerned about topical steroid withdrawal syndrome, or TSW. Things always sound snappy when they have an acronym such as TSW. It almost makes it like it's a recognized condition. It's also referred to as steroid dependency, steroid addiction, steroid rebound, or red skin syndrome. Now, the issue is it's a recent entity, and there's a lot of social media and internet traction with this. It's on TikTok, it's on Instagram, it's on Facebook. People are hearing about it a lot more, and I'm getting lots of questions about it. Now, the issue with TSW is it's poorly defined diagnostic criteria. So we don't have good clinical criteria to define what TSW is. There are lots of people who have their own opinion on it, but generally the thought is that people with long-term use, and these are adults who are on TikTok who are defining long-term use of topical steroids, and then because they're using these topical steroids, they've experienced increased redness, burning, itching, flaking, photosensitivity, pustules, infection, wrinkling. All of these things have been described. And unfortunately, all these symptoms describe not just eczema, but a lot of different dermatological conditions. So it's hard to know what is actually TSW syndrome. And so when patients and parents come to us with this, it's actually hard to work out what they mean by it. So when you look, and these are posts that were from a few years ago, but it's in the paper. So serious warning about life-threatening side effects of skin cream used by millions to treat eczema and psoriasis. And, you know, not trying, this person on the right is not my patient. This is just something on ABC News, so it's on the public arena. But this patient has an Instagram account using topical steroids to help his eczema, but withdrawing left him in agonizing pain. So if we go to this, his Instagram account, so this is someone who has stopped using topical steroids and is healing from it. So this is an account from a few years ago, but he's got severe peeling, severe erythema, and it's terrible. And I don't want to comment on someone who's not my patient. Not that I can comment on my patients anyway, but he's not my patient. I don't know his situation entirely, aside from what he posts on Instagram. But it is absolutely terrible for him. I feel very sorry for him. He's going through a horrible time. But the frustration is that these people have chronic eczema that they've had since childhood. And I looked at his Instagram page from recently, and he's better than that picture, but he still has chronic erythema and still peeling of the skin, and he still states that he's still going through his healing phase of TSW 3 years later. So look, is it a real phenomenon? And this is controversy. So there was a recent talk at the dermatology conference whereby a lot of dermatologists don't feel it's a real phenomenon. The problem is self-diagnosis. So a lot of adult patients saying, look, I've got this because I fit the criteria. The criteria being I've used topical steroids since I was a kid, I've stopped using it, and my skin's gotten a lot worse, I've got TSW. But as I said, there's a broad range of symptoms and signs. Now, what is true? Certainly we see rebound phenomenon with oral steroids. So often we tell people not to prescribe oral steroids because if you do that, that's a high dose of steroids, and when they come off it, they can get a worsening of their psoriasis or their eczema. And do we see that with potent topical steroids? I think you do. So I do believe that there is a rebound with oral steroids, and I do believe that you can get a rebound or worsening of eczema if you use potent topical steroids that stop suddenly. I don't think there's an issue with that. But, however, eczema is a chronic condition. And so when the eczema comes back again after ceasing topical steroids, is it simply a flare of eczema when the treatment is ceased and when there is a chronic condition in the background? So often I'll say to parents, look, if you have a chronic condition, you all have patients with high blood pressure, and you need to treat that with, if they have dangerously high blood pressure, with an antihypertensive. But if you stop that antihypertensive, what happens? The blood pressure goes back up again. Well, then do you have high blood pressure withdrawal syndrome? Okay, if you stop taking insulin for your type 1 diabetes, do you have insulin withdrawal? No, you have a condition which returns when you stop it. And I think the case is many people who diagnose themselves with TSW may in fact just have a flare of their chronic eczema. But there are other diagnoses that are possible. So we do know that if you use steroid creams on the face, you can get steroid rosacea. You can get periorificial dermatitis. Some of these patients I've seen who come to me with TSW, I actually say, no, you've actually got periorificial dermatitis. You've actually got a different diagnosis, and we need to treat you with oral antibiotics or topical treatments. But they have another diagnosis. There is the other possibility of the wrong diagnosis of seborrheic dermatitis, which is in the background, or allergic or irritant contact dermatitis. So there's other things you need to think about when people have TSW. And so remember, patients with chronic eczema have been frustrated their whole lives with terrible skin disease, where we have until recently, and I'm sure Nick will talk about it in his talk, but have until recently had very bad treatments. But now with biologics, we've seen a great change. But I can understand their frustration and people being frustrated with topical steroids. If we didn't have to use topical steroids, I'd be more than happy, but unfortunately is the gold standard at this stage. So this is one of my patients who came to me with 18 months of topical steroid withdrawal, whereby she just had severe untreated eczema. Absolutely tragic, absolutely tragic. So I put her on dupilumab, and it just fixes it, okay? Not because I felt that she had TSW, but she just had severe eczema and she needed a better treatment than topical steroids. Yes, topical steroids aren't great. She needed a better treatment than that. Fortunately, we have dupilumab, and her life has changed, and she's been on this for the last couple of years. So I'll finish off with what's my concern is Parents are then coming with their children thinking, I've read about TSW, I don't want to use topical steroids on my baby because I'm fearful that they will become an adult with TSW. And so it already is worsening what we have with fears of steroid phobia, people worried about thinning of the skin and other problems. So we're trying to get parents to use topical steroids because it is still the gold standard treatment and it's still the best option, because if we can get their skin under control, then it's much better and they're more likely to grow out of their eczema. So infants with eczema worsens over time and therefore they may need more potent topical steroids. And so that leads to parents' perception of steroid resistance. And inadequately treated infants lead to chronic eczema, and that increases the risk of infection, allergic sensitization, and other atopic diseases. So I talk about the atopic march, and if you don't treat the eczema adequately initially, then the barrier dysfunction leads to allergens getting through the skin and sensitizing them to be getting asthma, hay fever, and worsening eczema. And so the impact of infantile eczema on the entire family of loss of sleep, chronic scratching, it's just understated. So we need to treat the infants with eczema adequately earlier on. I want to finish off with this case that I saw just last week. And this sort of ticked a few boxes and the parents gave permission to use this as an example. So this is your typical child with eczema. Firstly, started off with a bit of eczema, 6 months old, at 2 months, started off with eczema a bit behind the ear. Parents used 1% hydrocortisone, fantastic, it worked. But the eczema went to the cheeks. Use 1% hydrocortisone. Oh, it didn't work as well. It got worse. It spread. Oh my gosh. I read about TSW. You need to use, the GP suggested using a stronger steroid. Oh no, I don't want to keep using stronger steroids because I think we're going to lead to TSW because the eczema is worsening. No, the eczema is just getting worse with time. Mother was breastfeeding. Oh my gosh, I think I'm going to stop taking seafood and dairy and eggs. All these things, the white patches. Oh, I think the steroid creams left some white patches. So this ticked all the boxes that we address, and I'm sure you see this all the time. So we just have to redirect the parents into thinking the right way of using topical steroids adequately, having good follow-up and reassuring them with all the standard eczema treatments, which I know you all know how to do, but these are the challenges that you face and they're ones that we face as well. So I'll end with that, and sorry for going over time.
It's good. Thank you, Andrew. So our next speaker is Dr. Nita Agar. So I'm sorry, but I have to remind everyone, all the speakers, that we only have 15 minutes each. So please keep time. No, thank you. Thank you. Well, also it's really very interesting presentation. So all right. So if I may ask Nita to start. Thank you.
Great. Thanks so much. And like Andrew, I just wanted to say thank you to everyone. Can you see me? Can everyone see that full screen?
Yes,
thank you.
Great.
Okay. Yes. So we're very grateful for the opportunity to be able to talk to all of you about skin. I know you see a lot of it in your work. And we love doing the face-to-face when we used to have the opportunity to do that, because we really like to put faces on the people who we know by paperwork and by the patients that we share. So I work at Sydney Skin and I work at RPA Hospital. We're talking about rosacea today. And I just wanted to make it a bit of a practical talk. So I'm going to try to walk you through patients as we would see and I would manage them, so that hopefully it can help you when you're dealing with your next patient. So case one. Classic patient who is going to come through your door, normally a female, is coming in because she's been really self-conscious of the facial redness and flushing. Initially, it kind of comes and goes, and then it kind of is persistent, and that's when they get worried. For young men, they often come because people are constantly telling them they look sunburnt, and they kind of are fed up of that, and that's what often drives them through. So very obvious for these sorts of people what sets them off. They've got the erythema on their face. They can tell that when they're in the sun, when they're exercising, hot showers, alcohol, that all sort of sets them off. What they should be asked, and the thing that I just encourage all of you to just think about, is just to ask the patient about ocular symptoms. Now, they're not going to put their ocular symptoms together with their skin. It's a bit like with psoriasis. We ask you to talk about psoriatic arthritis. Just ask them, have they had any issues? Normally they talk about grittiness, dryness. Sometimes they just get issues of styes, blepharitis, conjunctivitis. That's the sort of thing that people can get with rosacea, just to try to see if there is any symptom on that regard. And the other thing that you just will ask them about, and that they may also explain, is that they get dry skin, skin sensitivity, burning sensation, is something that we feel is category of rosacea skin that's to be expected. So management, how would I manage that person? So my registrars always get told start with the general measures. They're going to have sensitive skin. They've got an impaired barrier. So we ask them to use a really gentle wash. Don't overstrain the skin. Moisturize, because they've got that dryness. It helps recover that barrier for them. Sunscreen, it's an obvious thing. They're worried about the redness. They really need to put the sunscreen because the sun's going to obviously exacerbate that vasodilation. And camouflage, it's such a simple thing. They're worried about the redness. Give them hints about camouflage. For the women, I say go to the beauty counters in the big department or beauty stores. They have lovely green tinted foundation that hides the redness better than some of the standard foundations. Tinted sunscreens, every brand will have them. For men, that can be a way of trying to cover that redness in a way that's practical. Obviously, triggers to recognize and to try to avoid. And then creams, I'm going to come back to the creams, but Rosex, Cilantro, Asclear are certainly some of the options. I think they work well for some people with redness. Sometimes I feel like we don't quite get there. Sometimes I get them to just treat half the face so that they can see if there's an improvement, because it's often a subtle thing for them to see. Movasa, I'm going to talk about in just a moment, because you should know and have this up your sleeve. And then there's always a role for vascular laser and IPL for these people for whom the redness is just the predominant concern. So causes of rosacea. In fact, when Andrew was going through his list of things that were causes of eczema, it's exactly the same list for rosacea. The bottom line is we don't know what's happening. I try to explain to my patients that they've got a disrupted barrier, but they've got this an imbalance in the skin microbiome, I think, is the best way to put it these days. There's lots of talk about whether people with rosacea have more Demodex mites on their skin, and that's the skin overreacting to it. Basically, anything that makes their blood vessels dilate will make them feel redder, and that's the triggers that we're talking about. You'll see number 7 in that little slide is gut health, and this is probably an evolving space. There's this whole thing about gut skin health, and we definitely do see more rosacea in people who have some of the inflammatory bowel diseases. It's a watch this space. I don't think the evidence is hard and fast, but it may certainly be changing over time. So triggers, really, like I was saying before, anything that makes your blood vessels dilate up will make you feel like your rosacea is worse. And so that can be environmental things, spicy foods because of the capsaicin, hot drinks. Again, it makes sense. And for every person, it's an individual trigger. So they just need to work out what's relevant for them and take the necessary precautions. So creams. So Rosex is topical metronidazole, antibiotic, kind of makes sense. We're kind of trying to recover that microbiome balance with the metronidazole. Cilantro is ivermectin. Again, makes even more sense if we think Demodex is part of the big issue of rosacea skin. Again, just a topical cream. The one in the middle, I think, is kind of the unsung hero that people often forget with rosacea and acne. So azelaic acid, just to remind you, it's antimicrobial, it's anti-inflammatory, it's kind of mildly keratolytic, so it's exfoliating, and it's off the counter. So they don't need a script for this one. The limiting factor with it is, unfortunately, it can really irritate the skin. And so sometimes that's why they just can't kind of push through. So Movasa, for those who don't know, is really there to just temporarily vasoconstrict the skin. Works brilliantly if you can get used to it. I normally say do some test sessions when they don't have an important event, because it works well where you've applied it and just want to have an even application, and they can go online and see that. Works within about half an hour, and the company will say it'll last for about 12 hours. So there for people who need it for special events. The Americans will tell you that they could use it every day. I kind of say it's expensive, maybe use it when you need to. And like I said, the results can be fantastic. There are people who shouldn't be taking it, depending on what medications and other medical history they have. But one of the issues we have is sometimes when it wears off, people feel like they get a bit of a rebound redness, so they feel like they get redder than they were before. Second patient. So same thing with the redness, but now you can see the little papular pustules. They're still small, and again, a more classic age range, as we know, we tend to see the rosacea more in kind of middle-aged men and women. And the presentation from my end is classic rosacea, but if you can't be sure, just to remind you that there are no comedones in acne, in rosacea, sorry, which differentiates it from rosacea. So management, for her, I'd be trying the topicals. I think the topical creams will all work well, depending on your preference. In terms of what works probably from the trials the best, ivermectin theoretically works better and faster for the papulopustular rosacea. Then metronidazole or azelaic acid. So I'd probably be going cilantro first for that person if I was choosing an agent, and tends to be well tolerated, only once a day. If she had this sort of acne, sort of rosacea, where she's getting quite a lot of inflammatory lesions, I'd be thinking about oral antibiotics for her, really, because I want to calm her down and clear the skin down. And we've just got a better chance of doing that with the orals. Now, if we can't manage with the antibiotics, they're not hitting the mark, then we obviously will be starting to talk about low dose Roaccutane. So just to keep that in the back of your minds for those stubborn papulopustular rosacea. I do need to have a quick spiel about antibiotics. We're probably one of the big groups who prescribe antibiotics, but we just want to run through a little bit about how we use it so that you can also hopefully do the same. So I would use doxycycline, 100 milligrams daily. It's just once a day. That's easy for them to remember. They get a month's supply in 5 repeats, so you can give them plenty of it. I wouldn't bring them back for 6 weeks. So if I have two sort of things that I'd comment about where I think GPs probably a little bit sort of lapse is that they probably don't go for long enough and hard enough with the antibiotics. So what I'd say is go for the right dose and go for the 6 weeks and then review to see if you've got the response. And then alternates, minomycin, I'd have the same dose, 100 milligrams, and erythromycin is an alternate. Just to remind you about the doxy side effects. So the really important ones for you to please mention: photosensitivity, I think everyone knows about. Headaches, please mention headaches, because it can cause benign raised intracranial pressure, and you just don't want that to be happening to your patient. And then that pill esophagitis, they cannot lie down for half an hour after taking the doxy, because it can be a terrible thing. And I've had young girls who've kind of been on it for their acne who've ended up at the ED because they thought they were having a heart attack, and it's just the reflux esophagitis. How long is the other question. So this is a difficult thing because we know it's a chronic condition. I tend to taper slowly. So once they're clear, I would then drop them to second daily on the 100, and then I'd drop them down to 50 milligrams, and then I try to get them off it. Now, there's a difference between the anti-inflammatory and antimicrobial dose. So just to let you know, 100 milligrams would be an antimicrobial dose. Once you're down to 50 milligrams of doxy, you're on an anti-inflammatory dose. In many parts of the world, they have a slow release doxy, which is a 40 milligram, which is approved for rosacea. Unfortunately, we don't have it in Australia. So I tend to just say lower down the dose, and they may take 3 tablets a week, whatever's the minimum to keep them going. Have to emphasize that there's no cure. We're talking about a long-term condition. So really it's the patient's choice. If I can, I try to get them off the antibiotics and try to get the creams then just to maintain things. If they're flaring constantly, then I ask them, do you want to just take it, stop, and then take it again when you have a flare, or continue with low dose, but try to take the lowest dose that you can manage. It really has to be an individual choice, because unfortunately we can't predict the way that the rosacea is going to go. And I definitely consider referral if they're on full dose doxy or any of those antibiotics and they can't come down or come off it. Send them over for at least a conversation about what the alternates could be. Bit of a scary slide, not to completely intimidate you, but why do we not use minomycin? Look, the honest answer is, as a dermatologist, I love minomycin. I think it's actually probably a much more effective antibiotic, and we use it all the time, as you will see. There is an issue about blue-grey pigmentation with long-term use, which you need to know about, and we do see patients who've got this pigmentation and who've been taking the minomycin for the rosacea and not kind of figured out. She looks a bit scary because the pigmentation hits the sclera as well. You can also get acute hepatotoxicity on minnow, so just to remember, and there is a funny thing called drug-induced lupus from minomycin. Just to mention briefly that there are non-medical treatments. So there's a treatment called Floresca, which dermatologists do in their rooms, which is a medicated cream and light treatment. And for people who don't want to take the medications, who can't, then that is an option, but it's a costly an expensive procedure because it's obviously not at all covered by Medicare. Just very quickly, just wanted to remind you guys about the ocular rosacea, because like I said, it is a phenomenon and people will often have the symptoms but not have related it to their skin. So dry, greedy eyes, inflammation, ocular rosacea, I would send them to the ophthalmologist for them to advise. Lubricants, so natural tears, eye drops as they would, and sometimes the ophthalmologists will put them on low dose doxy as their management. And then the last case, elderly gentleman, tends to be a male sort of phenomenon where they have that thickened nasal skin, and you'll all recognize that as rhinophyma. So management for that, really they're there because of the appearance. I'd normally send them for reshaping, surgical, but these days we'd be really talking about CO2 laser reshaping for it. Can work really well for the people who want to go through that procedure. And then obviously you need to address the underlying rosacea, and we'll often have them on Roaccutane to try to manage it. In our rooms, Dr. Sebaratnam is the person who manages that treatment. And just very quickly, just before we finish, just the DD, people often wonder about acne and rosacea. Like I said, the comedones being present tells you it's acne. No ocular issues tells you it's acne. Lupus is the other one that's sometimes hard to distinguish. Lupus spares the nasolabial fold, while in rosacea you'll see it goes right past that. And then you have all the other systemic symptoms that will help you go. So just to cap off, just the take-home points from my end, really identify the subtype for targeted management, consider the ocular involvement, please do ask about that, use the appropriate dose of oral antibiotic, delay your review. This is true for all of our treatments for acne or rosacea. We always say 6 weeks of treatment and then we'll take stock because it will take time. Refer if it's not improving or if you can't get off the oral antibiotics. And I just wanted to remind you all that vascular laser for rosacea is partially covered by Medicare. If they've got quite obvious telangiectasia and that, then they would get a rebate.
Good. Thank you, Nita. That was an excellent and concise update. Our next speaker is Dr. Nicholas Stewart, and his topic is on injectables and biologics. Thank you, Nicholas.
Hello, everyone. Thanks for the opportunity to talk to you all today. So the topic I was asked to present was biologics and small molecules. So I'd like to thank Dr. Anna Bandera. So she's another dermatologist that works at Sydney Skin, and she helped prepare this talk. So biologics and small molecules. Biologics, just as a background, are usually large immunoglobulins. They can be human or otherwise. They're large molecules and they need to be injected. So they can be an infusion or an injection, and they usually end in MAB if you're getting confused with all the long names. Small molecules are more of a sort of a flavour of the month. More of them are coming out in dermatology. These are ones that I work on inflammatory pathways, most notably the JAK-STAT pathway, and they're orally available. So patients often prefer them, and they usually end in INIB, INIB. So that can help you sort of navigate through these large words. I think the other thing about both the biologics and the small molecules is that the names of these medications are just fun to say, and they automatically give you some sort of credibility with patients, make you feel smart. So I'm going to go through. So these would be the big 4 diseases where both the biologics and the small molecules are making a lot of headway. One of the things that happens is when a new medication is released, often there is a lot of fanfare. There's media. They're on the Today Show, patient stories and that sort of thing. And so you get quite a lot of excited patients coming in to try these state-of-the-art medications. Just as a quick reminder, the way drug development works, I mean, it's all done by big pharma, and they spend lots and lots of money trying to get these drugs to market. And so when they've jumped through all the hoops, they go to the TGA, and the TGA approves it. Now you can then write a private script, and those private scripts will be very expensive because they're new medications, and the drug companies wants to recoup their costs and make profits because they're a company like any other. And the next stage, of course, is to go to the PBS, and that's when it's a bit of a party because the patient doesn't have to spend a lot of money because the government is paying the bill. The drug company is going to get, what they want. The trouble is that the Australian taxpayer obviously pays the bill, and so to keep that in mind, when we talk about some of these medications like alopecia areata, so alopecia areata is one of the most common is the most common autoimmune hair loss condition. And traditional treatments for when you have alopecia totalis are things like oral steroids and steroid-sparing agents. I'm sure Dr. Chen will talk much more about that. But reports came out about baricitinib. The trade name is called Olumiant, and so it's a JAK inhibitor, and it miraculously can regrow hair in people with alopecia totalis. And so when people come in, they say, "Oh, I'd like to take that drug, please." And you say, "Not a problem. I'll just have a look online, and I can tell you how much a private script for that will cost, because it is not on the PBS for this indication, and you'll be paying sort of $1,046.34 for a box. Do you still want me to write that script for you?" And most of the time they say no. But every now and again, someone does come in with deep enough pockets, and you get to try these things out and see if it's worth the hype. And so here's a patient of mine from Dubbo who had some bad alopecia areata. He was willing to try things. One of the ways to get around the cost is with compounding pharmacies. And that can help keep some of the out-of-pocket costs down. There are sort of strict rules about compounding pharmacies, and there was sort of a semi-recent crackdown on compounding pharmacies. And so you have to obey the rules and do it strategically, but it can help. And you see here the results of him taking modified form of baricitinib. Sort of he grew hair, and it seemed to do what it said it was going to do on the box, which is great. Vitiligo. This is another JAK inhibitor called ruxolitinib, and so this lady's been putting it on for her facial vitiligo, and you can see after a year's worth of treatment, she's got some very pleasing repigmentation. And of course, as soon as these drugs are released and these studies, you can go to compounding pharmacies, and they will charge a decent amount of money to have a go at these things. But most people want to wait until it gets on the PBS, and so I thought, given that, it might be worthwhile to talk about things that are on the PBS, because these are the ones that generally we get to help patients with more. And so atopic dermatitis, psoriasis, and those sorts of things. Psoriasis is a very common condition. 1 out of 50 people walking around out there will have psoriasis. And this is what the current therapeutic ladder looks like. You have got topical treatments for mild disease, and then phototherapy. The classic systemic treatments were methotrexate, cyclosporin, acitretin, and they're still all commonly used. But there are some new systemic agents and small molecules, so apremilast and deucravacitinib. And then, of course, the biologics, which work on the anti-TNF. The originals worked on the anti-TNF pathway and IL-12/23, and the more recent ones do IL-17 and just IL-23. So, not to bore you with details, but when people come in with their psoriasis, if we want to try and get them on a biologic treatment, it's not as simple as writing them a script. They need to go through a whole treatment journey. And what this means is that they need to have bad psoriasis, or PASI, which you can see here is just a way of scoring someone's psoriasis, and it needs to be very severe psoriasis. They need to have it for 6 months, and they need to have failed a bunch of things. And so people need to be patients need to be made aware of this process, because a lot of the time they think, I'm going to go in and get this script today, and that's just not going to happen. Whereas the newer, smaller molecules are actually much easier to get. As far as getting access to them on the PBS, you need to have severe psoriasis, but there is no cutoff with a PASI, so you just need to decide that it's severe. They say it needs to be chronic, but there's no time limit, as there are with the biologics. The only hurdle is you have to have some reason. They either have not responded to methotrexate, or there's a decent reason why they can't have it. And so the first one that came out was apremilast. It was a great drug in 2014, tablet taken twice a day. It works on a phosphodiesterase pathway, and that pathway produces IL-22. So it's basically it works on the same pathway as sort of trem-5 and ustekinumab. Sorry, IL-17, so like a Cosentyx type pathway. And all this slide basically says is that the clinical trials demonstrated that it's effective for moderate psoriasis, but it wasn't quite as effective as the biologics. A later study came out which basically demonstrated that it works for severe psoriasis, or moderately severe psoriasis, as well as mild psoriasis, but it's much more effective for mild psoriasis. And then, as far as safety issues, is it safe? The answer is yes, it is absolutely safe. It gives you some GIT symptoms, but that tends to be the most limiting factor, but you don't need to have any screening or monitoring or anything like that, compared to some of the traditional medications like methotrexate and certainly cyclosporin, etc. So the new kid on the block, deucravacitinib, fun to say, it was approved in 2022. It's a tablet taken once daily. It works on the JAK kinase pathway, and it blocks a thing called TYK2, which gives it its trade name, so TYK2. And what was interesting about their studies is that they put them up against their competitor. Most drug companies, when they do their studies, they'll compare it to a placebo, or they'll compare it to something which they know is going to be an inferior competition, so like mild topical steroids. But they went straight for apremilast, which was out, and they wanted to compare their product to that, and basically showed that it was more effective. So a PASI 75 is where you can reduce someone's psoriasis by 75%. A PASI 90 is when you can reduce it by 90%, and it could do so in sort of 50 and 30% respectively of patients, and so it was more effective. Apremilast is the one that's in orange, and the deucravacitinib is in blue. They also showed that it maintains its response after 4 years. So this is sort of some long-term data which has only just been released. And that was for the whole body, and it also maintains its response over 4 years for scalp and fingernails, keeping in mind that in Australia, having psoriasis in your fingernails and in your scalp would not be an indication to take these medications anyway. You need to be on a trial. Deucravacitinib is also good for psoriatic arthritis, so about 20 to 30% of patients with psoriasis develop psoriatic arthritis. And if I see a patient that's got psoriasis and they complain of sore joints, I sort of tell them to go and see a rheumatologist, because my abilities are only skin deep. And generally then there's some dialogue between which medication should we start them on. And in my hands, if someone's getting worked up for a biologic and I get to choose for their skin, I almost always go for an IL-23 because they're safe and very effective, but they are underwhelming for joints. And so rheumatologists often push for an IL-17 or a tumor necrosis factor blocker, and usually in combination with methotrexate. So is this medication safe? Yes, it's again very safe. There's no indications of anything in terms of heart attacks, cancers, or those sorts of things. And 4-year safety data. You don't need to do any screening or monitoring for these medications, so they're very easy to put on, as opposed to again methotrexate, cyclosporin, etc. The only thing about screening is that people with psoriasis is a systemic disease, and so they are at risk of heart attacks, and so they need to be screened from that point of view, but not because they're on this medication. And as far as side effects are concerned, these small molecules that have safety and no side effects like their biologic counterparts, and there's no changes in laboratory results. So then what happens is a whole bunch of very prestigious doctors get together, and then they review the literature and they say, we think that this is great. And so that's basically where we are with these medications. And so my personal experience has been that medications are very good for people who need to have a systemic or would benefit from a systemic agent. And if they fail it, you can then use that as a reason to get onto a biologic, which are arguably more effective. But having said that, I've got a number of patients who get sort of caught in this with these medications because they're so effective. Their skin is clear, they're very happy, and they just come in every 6 months to get their scripts. And you can be very sort of relaxed about it because all of the data indicates that they're very safe and effective drugs. And basically, when you look at the head-to-head trials, deucravacitinib is the one that works the best. And so with the limited time that I had, I thought, we'll probably just talk about psoriasis. I've left eczema and some of the other ones off, and perhaps we can have a chat about them another day. But like I said, the ones that are really sort of coming out at the moment are the IL-17s and IL-23s. So thank you very much for the opportunity.
Well, thank you, Nicholas. Yes, that was very quick run through all the biologics. I'm sure if you have to go through it properly, it will take about 2 hours. So, so thank you. So our next speaker is Dr. Andrew Chen, and his topic is scalp conditions and hair loss. Thank you.
Thank you. Due to the time limit, I will only be covering the more common scalp and hair loss conditions today. So dandruff, seborrheic dermatitis, scalp psoriasis, and pityriasis and echinacea are similar conditions with overlapping clinical features of scaling, erythema, and inflammation. However, they differ in severity and are therefore given different diagnoses or labels. The treatment for them, however, are quite similar. With dandruff, there's scaling and skin flakes on the scalp and hair. With seborrheic dermatitis, it's a bit more severe. In addition to scaling and skin flakes, there's also erythema and inflammation. And sometimes other body areas, such as the face with the eyebrows and the sides of the nose, can be affected. With scalp psoriasis, there are erythematous thickened plaques covered with silvery scales. With pityriasis amiantaceous, it's even more severe, with thick scales adhering to the scalp and hair shafts, causing them to be matted together. When the presentation is more severe, such as with pityriasis amiantaceous and scalp psoriasis with thick scales, a three-step process to remove the thick scale first is helpful. This is because if the thick scales are not removed, topical corticosteroids tend not to work, as they cannot penetrate the scale to act on the skin, to go to the skin where it needs to act upon. So the first step is to use a compounded salicylic acid preparation, such as 6% salicylic acid in olive oil. The patient will leave it on the scalp and hair for about 1 hour to soften the scales and then to remove them. They may want to cover the head with a shower cap if they want to. The step 2 is to use an anti-inflammatory shampoo, such as a tar shampoo. Step 3 is then to apply the topical corticosteroid lotion. The steps 1, 2, 3 can be repeated daily until there's no more thick scales remaining. Once there are no thick scales, or the condition is not severe to begin with, such as with only dandruff or seborrheic dermatitis, the patient can maintain their usual scalp health with anti-inflammatory or anti-dandruff shampoo, such as a tar shampoo or ketoconazole shampoo. If required for inflammation and itchiness, they can also use a topical corticosteroid lotion. Lichen simplex chronicus is when the skin is thickened in response to scratching, and scalp is a common area because it's easily reachable. There's the vicious itch scratch cycle, in that the more a person scratches, the itchier the skin actually becomes. So this is an example of lichen simplex chronicus with thickened skin on the patient's posterior scalp. A characteristic feature of lichen simplex chronicus is when you can see exaggerated skin lines, as demonstrated here. With lichen simplex chronicus, what happens is that the skin will thicken naturally whenever it is scratched. Therefore, the cure of lichen simplex chronicus actually requires the patient not to scratch, which is difficult to do. However, the urge to scratch can be eased with the use of a potent or super potent topical corticosteroid. The topical steroid can also help thin the skin faster, so the plaques will resolve faster. However, the use obviously needs to be monitored to ensure that there are no unwanted side effects. Additionally, an anti-inflammatory tar shampoo can be used as an adjunct to reduce the itchiness. Scalp folliculitis is when there are erythematous papules and pustules centered on the hair follicles on the scalp. It is thought to be an abnormal immune reaction and inflammation to organisms that normally live on the scalp. So this is a photo of scalp folliculitis. This is another photo which shows that the pustules are centered exactly on the hair follicles. Treatment options include using an antiseptic wash to reduce organisms, or to use a tar shampoo for their anti-inflammatory measures. If it's more severe, then using a low-dose anti-inflammatory antibiotic such as doxycycline, which often used for rosacea, as Dr. Agar mentioned, and also acne, can be quite helpful as well on the scalp. If it's more severe and resistant, then a low-dose oral isotretinoin can be considered. Erosive pustular dermatosis, presents with inflammation, pustules, crusts, and erosions on the scalp. It is typically seen in elderly men with sun-damaged, bald scalp. Clinically, it can be very difficult to distinguish from skin cancers such as SCCs. So this is an example of erosive pustular dermatosis with an erosion and crust. This is a more severe case, and this is an even more severe case where almost the entire scalp is affected. To manage this condition, the patient will firstly apply saline salts to the scalp for about 5 to 10 minutes to soften, and then they can gently remove the crust. This is followed by an application of a potent topical corticosteroid. They will do these steps about 1 to 2 times a day until they come back in about 2 to 4 weeks for review. Usually, if it's erosive pustular dermatosis, almost all the skin should normally return to just about normal. But if there's anywhere that is persistent, then the biopsy needs to be considered to exclude skin cancers. Pilar cysts are keratin-filled cysts that originate from the scalp hair follicles. Clinically, they look very similar to sebaceous cysts. They are also familial cases of pilar cysts with an autosomal dominant pattern of inheritance. So this is a photo of a pilar cyst. This is another photo where the patient has a couple of pilar cysts. If the cysts do not bother the patients, then obviously no treatment is an option as they are benign. But if they do, then they can be excised surgically. If you simply drain the cyst, they actually don't normally go away because they have actual cyst walls. So the cyst content will reaccumulate. Tinea capitis is a fungal infection of the scalp caused by dermatophyte species that are usually seen in pre-adolescent children. This is an example of tinea capitis with inflammation, scaling, and alopecia. So this is more severe with bigger area of alopecia and also broken hairs presenting with the characteristic black dots that we can see on the scalp. There's an abscess on the scalp here due to a severe inflammatory reaction to the fungal organisms. This is also known as a carrion. Some dermatophytes, such as Microsporum canis, fluoresce under UV light. Therefore, a Wood's lamp can be used to help with the diagnosis of tinea capitis. However, a negative Wood's lamp doesn't exclude tinea capitis, as not all dermatophytes fluoresce. If tinea capitis is suspected, you can pluck some hairs and do a bit of skin scraping and send for fungal microscopy culture, and nowadays PCR. It can be treated by antifungals such as griselwolfen at a dose of 10 to 20 milligrams per kilogram up to 500 milligrams daily, usually for about 6 to 12 weeks. Alopecia areata is an autoimmune condition affecting the hair follicles. The lifetime risk is about 2%. It can affect both children and adults. If it happens in children, the prognosis tends to be worse. So this is an example of an alopecia areata with a patch of alopecia. This is another example. If you look closely, you can often find the exclamation mark hairs, and that's where the hair tapers at the base, resembling an exclamation mark. So this is a characteristic finding of alopecia areata. Sometimes the alopecia can be very severe, where almost all the hairs on the scalp can be is lost. It is not a harmful condition. However, treatment is often indicated for cosmetic and psychological reasons. When the alopecia is mild with 1 to a few patches, a super potent topical corticosteroid such as compounded 0.1% clobetasol foam can be considered, or to use an intralesional steroid injection as an adjunct. Topical 5% minoxidil can help promote hair growth. When it is more severe, systemic therapy such as prednisone, methotrexate, and nowadays JAK inhibitors, like Dr. Stewart has covered, can also be considered. Male pattern baldness is very common and affects almost all men to some degree. There is diffuse thinning of the hairs in their frontal scalp and scalp vertex, together with receding hairline. So this is an example of male pattern baldness with receding temporal hairlines and thinning of the hairs on his frontal scalp and scalp vertex. With dermoscopy, on the right is normal scalp with about 2 to 3 hairs per follicle, and the hairs are of normal diameter. On the left is male pattern baldness, where there are less hairs per follicle, and additionally, there are many hairs that are miniaturized with a small hair diameter, which is a finding of male pattern baldness. If the patient is not bothered by the hair loss, then obviously no treatment is an option. But usually by the time they come and see a doctor, they do want treatment. The first-line therapy is often minoxidil, which can either be topically as a solution or foam, which patients can buy without prescriptions, or if they prefer, they can also be compounded into tablets, usually about 1 milligram daily to begin with. If top minoxidil is not working well for the patient, then the next line option is usually oral finasteride. Other options can include cosmetic camouflage, such as with hair fibers and hair transplant. Female pattern baldness presents with diffuse thinning of hairs on the frontal scalp and scalp vertex, similar to the male pattern baldness. However, there is usually no receding hairline. So this is an example of female pattern baldness. The dermoscopy findings are the same as you would see in male pattern baldness. Again, if the patient is not bothered, then no treatment is an option. Otherwise, the first-line therapy is often minoxidil. Second-line hormonal therapy options can include spironolactone and finasteride. Telogen effluvium is a temporary hair loss due to excessive shedding of telogen or resting hairs around 3 months after a shock to the body. Examples include giving birth, high fever, surgery, weight loss, and psychological stress. Unlike male or pattern baldness, there is not a pattern and the entire scalp is affected. So it's an example of telogen effluvium. You can see that her kind of temporal entity, her parietal scalp is also affected, where it's normally spared in a pattern hair loss. Often the patients will bring hair to actually demonstrate to you how much the hair they are actually losing. So even though the amount of hair that patients losing can be quite alarming to them, but they can be reassured that the hair loss is temporary and will self-resolve. Often there can be concurrent male or female pattern baldness, which can be treated, for example, with minoxidil. And you often do screening blood tests, such as FBC, EUC, LFT, iron studies, and TSH. And if there's anything abnormal, obviously, it would be helpful to have it corrected to help promote hair regrowth. Thank you.
Oh, thank you. Thank you, Andrew. So that was a very excellent insight into the topic. So our next speaker is Associate Professor Li-Chuen Wong. Her topic is hemangiomas of infancy and other neonatal conditions. Thank you, Li-Chuen.
Oh, Andrew, I think you might have to stop sharing. Is that good?
Yes. Yeah, we can see it.
Can you see it?
Yes, we can.
Okay, that's the most nerve-wracking part Thank you for everybody for your patience. And once again, thank you for your time this evening. We really do appreciate this is a weekday school night, and thank you for your time. So I'm going to now whip through neonatal dermatology and hemangiomas. The first, let's go through a few lumps and bumps that we're all familiar with. Okay, so first on the left, we have neonatal acne, which is also called neonatal cephalic pustulosis. And it's the presence of these small red pustules on the cheeks, chin, and forehead. And they often appear a bit later than erythema toxicum, around 3 weeks of age. And they can persist for months, waxing and waning. And it's thought to be related to Malassezia furfur, which is the yeast, the commensal yeast that also causes, as we know, seborrheic dermatitis. It will spontaneously resolve, and so therefore doesn't require any treatment. But if parents really want to try something, I use topical Nizoral or ketoconazole. In contrast, infantile acne is the development of blackheads and whiteheads, that's the key, as well as pustules, papules, nodules, and cysts that develop slightly later, around 3 months of age, and can go on till about 2 years of life. And it's more common in boys, and it's thought to be the result of the transplacental transfer of testosterone from mum through the placenta to the bub. And in susceptible patients and children, it causes the development of acne. Now, these kids are perfectly healthy. They don't have a background hormonal issue, and the acne will usually subside by 2 years of age. However, in terms of treatment, I use a topical retinoid, usually adapalene or Differin, because it's quite gentle and elegant and used at night, washed off in the morning, or compounded 2% erythromycin and Cetaphil lotion applied twice a day. Sometimes, though, the cysts can be quite big and painful, but more concerning is that it can lead to long-term scarring. In situations like that, I give oral erythromycin or even very, very low dose isotretinoin or Roaccutane. Now, the majority of these kids, as I said, will clear spontaneously, but be aware that these kids often then present in adolescence with severe and problematic acne. Now, this is a birthmark seen at births or sometimes shortly after, and it is a yellow, greasy, verrucous-like nevus. It's a sebaceous nevus, which is an overgrowth of too many normal oil glands, usually in this ovoid or linear appearance on the face, but generally the scalp and the neck region. Around puberty, it often becomes thicker, more warty, and when kids comb their hair, it catches on the comb and it bleeds. So usually kids want it removed. The other reason why it can be useful to remove is that around 10 to 20% will develop a secondary tumor within it, generally a benign tumor called a trigoblastoma, but sometimes a basal cell carcinoma. However, sometimes the sebaceous nevus can be quite enlarged and can go in this very special, what we call a Blaschkoid distribution. So very swirled whorled lines, which are the lines in which birthmarks follow, or the lines of Blaschko, how our skin develops. And a sebaceous nevus in this pattern will have that typical characteristic knot at the top of the head. Now, such a large lesion is often then associated with other issues, particularly neurological issues, eye issues, bone issues, and this is then called the sebaceous nevus syndrome. This is an epidermal nevus, which is an overgrowth of too many normal keratinocytes in the dermis, and it is a brown color as opposed to the yellowish color of the sebaceous nevus. It can also be extensive and be part of what we call the epidermal nevus syndrome. An epidermal nevus is generally found on the trunk and the limbs as opposed to the face and the neck of a sebaceous nevus, and can be cut out, or a keratolytic such as a tar preparation or a retinoid can be used to try and decrease the roughness and the thickening. This is a congenital melanocytic nevus. It's the collection of too many normal melanocytes in the skin, a type of birthmark. If it's small and less than 1.5 centimeters, which is the far left top photo, it is classified as small. A medium-sized lesion is between 1.5 to 20 centimeters, and anything above that is called a giant or bathing trunk nevus. Now, when a giant nevus overlies the spine, it's important to make sure that you image and do an MRI to exclude any neuromelanocytic involvement in the spinal cord and in the brain, because unfortunately these kids can then get associated seizures and developmental delay. These lesions often become thicker, more warty, and also coarse dark hair can come from the surface. So I say to use a depilatory cream such as Veet or Nair, or cut very short. And if they want, they can, of course, get it excised for cosmetic reasons. And in the larger lesion, there is an increased risk of a secondary melanoma developing in the order of about 2 to 5%. Now, the last lump and bump is this. It's the lack of hair or skin. The lack of skin, and it's called aplasia cutis. It's usually isolated, found on the scalp. And what we have to be careful about is if we ever see this sign of a ring of hair surrounding the aplasia cutis, it's called a hair collar sign. And it is the sign that perhaps underneath there is an underlying neurological deficit in the form of either a meningoceal or an encephalocele. And it's important then to do an MRI to exclude this. If it's a very superficial loss of skin, it will then heal like a scar. Nothing needs to be done. If, however, it's problematic for the patient in terms of cosmesis, then of course send to a surgeon for removal. All right, now going through vascular lesions. The first we're all so familiar with, a nevus flammeus, otherwise called a stalk mark, or a capillary malformation or ectasia. It's generally found in the glabella, but sometimes the bilateral upper eyelids, the sides of the nose, under the eye, as well as the upper lip, and of course the occipital region. It is said to go within 1 year of age, but I know many patients as adults that still have their lesions. And interestingly, eczema always goes and overlies these areas because they're very warm, and that's where they like to sit. This is a different type of vascular lesion. It's called cutis marmorata telangiectasia congenita, and it's the presence of, at birth, this beautiful marbled reticulate pattern that is generally found on one limb, an arm or a leg, with associated soft tissue atrophy, sometimes ulceration. But the wonderful thing is no treatment is required, and it completely goes by about 2 years of age. Now, this is our favorite friend, the hemangioma, which is a benign birthmark. It's generally never present at birth, but then it starts to grow between 1 to 4 weeks of life. It then has the potential to grow till 6 to 9 months of life. The superficial component grows till about 6 months. The deeper component grows till 9 months of life. Then it stays exactly the same size till 3 years of age. At 3 years of age, it will start to shrink and involute spontaneously, so that by 5 years of age, 50% will have completely resolved by itself. By 7 years of age, 70% will have gone. And by 9 years of age, 90% will have gone. Hemangiomas can also be what we call segmental, so they are in a segment. They can also be multiple, and the magic number to name it as a disseminated cutaneous hemangioma is 5. So anything more than 5, and obviously here there's like hundreds of them, is seen as disseminated cutaneous hemangiomas. And then important in this situation to make sure that other organs such as the liver, the lungs, and the gastrointestinal tract is not affected. Now, just going back here, as you can see, when you have hemangiomas near sites of importance, such as the eye, the nose, the mouth, with growth, it can obstruct vision, breathing, and the ability to suck. So very important to treat. It can also be near the ear, and with growth, obstruct hearing. Around the bottom, it can be incredibly painful to go to the toilet, to do a wee, to do a poo, and very messy. And in the bad old days, all we could offer to these poor kids were oral steroids, which were just hideous. I mean, it did the job and it arrested the growth, but the kids would then have such terrible reflux. They were cranky, they wouldn't grow, and everything was a mess. Thankfully, now we have beta blockers. So we have topical beta blockers, which is topical timolol, which I never use except for the most superficial, flat, small hemangioma, because otherwise it's generally ineffective. We then had oral propranolol given at 2 milligrams per kilo per day. And propranolol works well. However, it does cross the blood-brain barrier, and therefore kids can have night terrors and sleep disturbances. My choice now is oral atenolol, which I give at 1 milligram per kilo per day, and it doesn't cross the blood-brain barrier, and it is a daily dose. You always give it with food because it can cause hypoglycemia. The other options are vascular laser treatment for the residual telangiectatic component after it has resolved. And sometimes you can use it for the most superficial of lasers, but the most superficial of hemangiomas, but it is painful. And there's the question of whether to do it without general anesthetic or not. And then, of course, surgery for the residual redundant tissue that is left after resolution. But you would never consider cutting out a hemangioma during its active phase because it will self-resolve. So a couple of significant hemangiomas to be aware of. This is a hemangioma in what we call the beard region. And why it's important is that 60% then have an associated subglottic involvement, which of course with potential growth can obstruct breathing, and you need to treat immediately. Remember, beards can be high as well as low in the neck region. Perineal hemangiomas can often be associated with lower GIT and urogenitory tract abnormalities. And this is what we call face syndrome. So it's a segmental hemangioma on the face, but it's associated with lots of other issues such as posterior fossa brain malformations, arterial anomalies, cardiac defects and eye defects, and definitely needs further investigation for these systemic other issues. But this is a picture of how wonderful resolution can be. And of note, if you have a significant amount of superficial component, you will be left with redundant loose tissue. However, if the majority of your hemangioma is a deep hemangioma, it resolves beautifully with absolutely no scarring at all. This is called a congenital hemangioma. So it's the presence at birth already of a fully formed hemangioma. That's the far left top photo. But this is a Riche, which is a rapidly involuting congenital hemangioma. So of its own accord, it rapidly involutes, not by 9 years of age, but in fact by 14 months of age. In contrast, this is another type of congenital hemangioma, so it's present fully formed at birth, but it's a niche. It's a non-involuting congenital hemangioma. So it looks pretty much the same at 4 months to 2 years of age. So it should be excised if cosmetically an issue. Now, I'm going to whiz through this genetic condition and then stop. This is the presence at birth of a girl with streaky red blisters. And this is incontinentia pigmenti. It's a rare X-linked dominant condition where the genetic defect is found on the X chromosome on the Nemo gene, and it comes in 4 stages. So we have here the first red blistery stage. That is often misdiagnosed at birth as being herpes simplex. The next stage is then it becomes warty, very thickened verrucous. And then the next stage after that is you get these beautiful swirled hyperpigmented areas in a Blaschkoid distribution. And the 4th stage is in that areas, you will then get hypopigmentation or atrophy. Now, what's important is you get the skin changes, but then you also have to look at other organs. First, the teeth, because the teeth can be involved in terms of loss of teeth, conical teeth, no teeth. The nails might be missing or pitted or ridged. Their hair might be lost, so patches of alopecia, or brittle hair. Eyes may be involved with vascularity developing, and the most important thing is the CNS involvement, and they can develop these little kids' seizures. But if they don't get a seizure by about 3 to 4 weeks of life, then you know you're home and hosed. However, these kids can also have developmental delay and other neurological issues. So this is a condition that we will see when we do our baby checks, and it's important to pick up because of having to involve all our wonderful other colleagues. So I think I'm just going to end it at that because I'm way over time, but I'll just show you one picture. This is a picture of annular lesions on the face in a raccoon distribution, and this is neonatal lupus. Thank you very much.
Yes, thank you, Li-Chuen. Thank you for all these interesting but a bit scary photos. Our last speaker tonight is Associate Professor Deshan Sebaratnam, and his topic is genetic skin conditions. So thank you, Deshan.
Thank you for having me. Some of these topics will overlap a little bit with previous speakers, but let's launch into it. So a bit of a refresher on genetics. So you have your sperm and your egg, and they normally have, your 23 chromosomes. They come together, and then that divides to form your blastocyst, and then your morula, and then an embryo, and that's how babies are made. And when we think about most genetic conditions, we're sort of taught about autosomal or sex-linked diseases. And that's where one parent will have a faulty copy of a gene, and then that gets passed on to every single cell. And so an example of that would be something like neurofibromatosis. So every cell in a patient with neurofibromatosis will be have a mutation in the gene NF, and that's what we call a germline mutation. But there's also another pattern that can happen, and that's where you might initially start off with a perfectly normal single cell and then 2 cells, but then somewhere along the division pathway, you accumulate a mutation. So every single one of our cells actually has lots of different mutations. It's just most of the time they're not so important. So you can imagine in this cell, you've gone from 1 to 2 to 4 to, let's say, 8, and then you get a mutation. All the daughter cells from that cell are also going to carry the mutation. And this is what we call somatic mosaicism, because every cell is going to be a little bit different to the others. So this is an example of segmental neurofibromatosis. So this is one of my patients, and you can see she doesn't have the neurofibromas growing all over her body. She just has them growing in this stripe along her flank. So we're all actually mosaics, and we see this pattern a lot. Leach alluded to Blaschko's lines. So when you start off as an embryo, you start off as a ball, and then that has to turn into a tube. And so these cells then have to divide and come around and meet in the middle. And these are what's known as Blaschko's lines. So they reflect the embryological migration pathways of the cells forming a baby. And we see that in nature in other ways. So we're all actually zebras. We've all got stripes. It's just instead of black and white, we're all the same color. But you can imagine somewhere along that pathway, as the cells are dividing, if you accumulate a mutation, then you're going to get a disease that follows a stripe. And then there's other patterns as well. So this is an example of Monstera. And you can see that in some of the areas of the leaves, they're missing chlorophyll, but in other areas, it's still produced. And so these are some conditions which follow the lines of Blaschko. Leach already alluded to incontinentia pigmenti. There's another condition called Galt's syndrome. So in these areas, the skin is very thin and atrophic. And then there's another condition called Conradi-Huneman-Happel, and everywhere that's affected, the skin is sort of feathery and scaly. So these are all conditions in females, and these type of Blaschko linear conditions are a little bit more common in women, because in men, if you're XY, the genes are, the mutations are carried on the X chromosome, and they're lethal with life. But in females, we have XX, and one of the cells will be turned off through the process called lionization. And so these are the differentials of what I call the stripy girl disease, which we see in terms of neonatal Blaschko linear diseases. So they're always following the lines of Blaschko. Here you can see that the rash is following and respecting the midline. So you can imagine all of the cells when they're migrating, if this side is the side with the mutation, when it meets in the middle, it'll respect that midline really nicely. So this is another example of NF. And then this is a patient with angioma superginosum. Again, you can see how nicely it's respecting the midline. I won't talk too much about epidermal nevus because Leach has already spoken about it. But again, you can see these Blaschko linear arrays of these verrucous papules following the lines of Blaschko. So as alluded to, you worry about the nevus itself and its impact obviously on cosmesis and things like epidermal nevus syndrome. But the other thing is, if these mutations are in areas where the gonads are, then there's a chance that they could pass this on to the kids, but it won't be as somatic mosaicism. Every single cell in the kid could have the mutation. So there's been a few cases of this reported where, you know, the dad might have a birthmark here, or in his case, probably more relevant along, you know, the iliac fossa. And this is caused by, so this birthmark is caused by keratin 1 mutation. But then if it affects his sperm, then every single cell in the baby is going to have the mutation. And so this is a condition called epidermolytic ichthyosis. And so I think there is now more of a role for thinking about sending these patients for genetic testing, because they can do things like, so in this patient, for example, they analyzed his sperm and about 10% of the sperm had the mutation and 90% didn't. And so now you can think about things like IVF or, you know, prenatal sort of planning for some of these genetic conditions, because the dad might just have a little stripe, but then the kid might have it head to toe. So that's an important thing, I think, to be thinking about. So these are slightly different to the lines of Blaschko. So here you have all of these swirled areas of hypopigmentation. And if you look further down on the lower leg, some of them have these sort of leaf shapes. So this little girl had autism as well. And she has a condition called hypomelanosis of Ito. So that used to be a discrete entity, but now we sort of think of it as a particular type of presentation. So all the workup for her autism was negative. Her blood work was all negative. But the thing that's really important is you need to do a biopsy for these patients because not every single cell in their body will contain the mutation. So we did a biopsy. It turned out that she was mosaic for trisomy 7. So now we have an answer for why she's likely to be autistic. That means there's not further workup needed. And so it's something where you will have a clinically actionable outcome. And so there's a reasonable argument for doing this. This is one of my other patients at Liverpool, and he is mosaic for trisomy 20. There's many other comorbidities. You can see the PEG there. He's had failure to thrive. Again, autism. And again, doing a lesional biopsy, we're able to work out what was going on. So this is the back of him. One little tip that can be helpful is examining the patients with a Woods lamp. So that's the lamps that you see at CSI. What it does is it releases light in the UV spectrum, so 365 nanometers, and then it can be helpful for pigmentary disorders. So we use it for things like vitiligo, hypomelanosis, but it's also helpful for things like melasma, looking or delineating the spread of melanoma in situ. And so that's just a little helpful trick. You can buy fancy ones, but I got one for $20 at Bunnings, and it does the job just fine. And then we move on to capillary malformations. So these are, again, examples of somatic mosaicism. They tend to be caused by mutations in GNAQ or GNA11. And so for a lot of these things, and I think with a lot of birthmarks, it's not just the birthmark itself, it's knowing what other systemic things do you need to be worried about or screening. So the one you need to worry about for capillary malformations on the face is Sturge-Weber, which you might remember from Talia and O'Connor. So just like you've got too many blood vessels on your face, you've got too many blood vessels in your eye, so that can cause glaucoma. And then you've got extra blood vessels in your brain, and that dodgy circuitry can lead to things like epilepsy. So what is in, it's not a very well evidence-based area, but sort of what's in vogue at the moment is to do some kind, so a baseline MRI and MRA, and then repeat this after a year. But after a year, you need a general anesthetic, and that's not without risks, and the likelihood of finding something clinically actionable is not necessarily that high. So it's an area of debate, and then lifelong off-thal review as well. So it's very rare to find something at baseline, but this little guy, even at his feed and rep, they found changes of Sturge-Weber, and then he went on to have seizures. And he also had glaucoma. He's had multiple drops, had surgeries and stuff like that. And he's getting vascular laser as well. So with the vascular laser, you can make a meaningful change in kids' lives, I think. So there's different ways of doing it. One way is to do the feed and wrap. So the treatment itself is pretty quick, but you need to get it done multiple times. It sounds pretty cruel, but I would rather do laser or biopsy any day compared to putting a cannula in a kid. With that, you don't know how long it's going to take. Whereas with laser or biopsies, you're not going to miss. It's got a very finite start and finish. And again, that can be the difference between sort of a kid getting bullied or just having to wear, tinted sunscreen in terms of camouflage. You can get side effects. You can see with this little girl, I've caused a little burn here. But I think on balance, superior cosmetic outcome compared to baseline. One of the things that you often get taught is, you can't treat darker skinned people with laser. So you can. This little guy's half Asian, half South Asian. I get vascular laser as well. I'm pretty dark skinned. So you just need to change the settings. And so vascular birthmarks is sort of an area of interest for me. So this is another condition. So this is, this gentleman has venous malformations as well as lymphatic malformations down his tongue and his neck. And so now we actually have targeted treatments for this. And so doing a biopsy or getting a genetic diagnosis opens up access to targeted treatments like alpelisib and some of the newer molecules as well. So again, he went to see genetics, had blood work. Blood work was all negative, but it was a biopsy from a lesional site, which helped open up the access to therapeutics. And again, this is a patient who had a capillary malformation, and he also has a venous malformation here, so two different types of birthmarks. And then I saw him again as an adult last week, and you can see that the birthmarks lightened, but now he's also started to develop these tiny little dots within his capillary malformation, and these are lymphatic malformations. And again, he's a confirmed PIK3CA patient as well. So in terms of genetic testing, I guess one question that's important is this going to change management? Because genetic testing is expensive. So if someone has textbook, neurofibromatosis, realistically, genetic testing is not going to be that helpful. But there are some situations where it might be. So the first thing is, if you have a confirmed diagnosis, is it going to change screening protocols? So things like, patients with tuberous sclerosis, they need quite close follow-up, or neurofibromatosis again. So that's something that's helpful. Is it going to open up access to medication? So the patients with vascular birthmarks, as I alluded to. And then if you have genetic testing, that can sort of lead to cascade testing where you, other family members might get access to genetic testing because of it. So that's one thing to think about. And then is this something where it's going to be throughout every cell in the body, in which case you can do, it's a germline process. And then you could do things like a buccal swab or a blood test, or is it something where it's an example of somatic mosaicism, where you need a sample from the area of change? And in that case, skin's very easy to access via a biopsy. So we've got a pretty neat setup at Sydney Skin. We've got all the stuff to do biopsies for kids, like nitrous oxide and stuff, to make it comfortable. And then sometimes for patients, I will walk it down to RPA, which is just across the road, because generally these, the genetic testing is done through the public. You can get it done privately. It costs about $1,100, and it just depends on which genes. And then again, I think a lot of people have this sort of perception that skin biopsies are not so easy in kids. But like I said, I would rather do a skin biopsy than take blood or put a cannula in a kid any day of the week. So one helpful resource is EviQ. So, when I passed the exam, I knew the screening protocols for every single one of the genetic diseases, and then they all change all the time. So EviQ is a great resource. There's no subscription. It's in Australia. It's not even Australian. It's a New South Wales specific resource. And for some of these rare conditions, so this is an example of Reed syndrome, but also tuberous sclerosis, NF, whatever it may be, it goes through all the things that you need to do. So you can, when you see the patient, when's the last time you had your MRI? And, you can tick the boxes that way. And so just a bit of a shout out for Sydney Skin. So one of the things that I always get in terms of feedback from my GP colleagues is that it takes forever to see a dermatologist. The big report that came out, one of the things they were saying, or that public hospital should have, is sort of a phone a friend mechanism. So this is the Sydney Skin website. If you are ever worried about a patient, there are mechanisms in place where you guys can get in touch with us. All the doctors at Sydney Skin are pretty good. Pretty much all of us have a public hospital appointment. And yeah, you can send through photos and stuff to help with triaging if needed. So that's the end of my talk. If you want to learn a little bit of dermatology by osmosis, I have an Instagram. It's targeted to medical people, not the general public. I practice a pretty broad spectrum of like medical, surgical, laser, peds, cosmetics. If you want to learn a little bit of derm by osmosis, that's me. FAQ was the resource. And then I think we'll invite all the panelists back for the roundtable discussion.
Thank you, Deshan. So that was a really complex topic. So thank you. So now it's time for our Q&A. Well, we only have about 20 minutes left, and we have 16 questions. So I'm afraid I have to be a bit more selective. I have to pick out some of the questions, and maybe we can answer some of the other questions in writing. We can look at that later. Anyway, so first question. Who qualifies for dupilumab and the contraindications and the most common side effects?
I suspect that one's for me.
Yes, thank
Yeah,
you.
I didn't talk about dupilumab. But yes, dupilumab it's biologic. It's used for atopic dermatitis. You need to be over the age of 12. You need to have with psoriasis you have a PASI score. In eczema you have a thing called an EASI score, which again is an attempt at an objective measurement to see how bad people's eczema is, and that needs to be over a certain number. And then they also need to answer a survey. It's called a DLQI. It's a quality of life type survey, like how unhappy are you with your skin, and if they score above a certain number with that. Sorry, I don't think you need to score above a certain number. It just needs to be recorded. And the other thing is a thing called a physician global assessment, where you look at someone and go, gee, that looks really bad. And so if you fill all of these sort of criteria and you have tried topical steroids, I think it's for 28 days, but I can't remember off the top of my head. I always look at the guidelines. And if you've failed topical steroids and haven't made a significant improvement, you'd be a starter for dupilumab. The great thing about dupilumab, again, is it's an streamlined authority script, so you can sort of provide them with one on the day of the consult. So yeah, hopefully that's answered that question.
Yes, thank you. So, all right, next one, rosacea. So what is the treatment for ocular rosacea, and can children suffer from rosacea?
So the answer is yes, kids can suffer from rosacea. It's not as common, thankfully, in that age group. The treatment for ocular rosacea, so to be perfectly honest, I would refer for getting natural tears and lubricants as the first line. If it's more involved in that, I'd always get the ophthalmologist to come in because I'm not the expert in managing conjunctivitis, blepharitis, and they have topical eye drops that they would do. They also do low-dose doxycycline. They have all the normal eye care that you'll be familiar with for people who have stars, kind of warm compresses and all of that. I think those people need an ophthalmologist to just kind of manage that sphere. If they've got ocular rosacea, they probably need that expert care.
Yeah, it's good. Thank you. So next question. So finasteride and spironolactone. So which one's more effective for female pattern hair loss?
For female pattern hair loss, I tend to use minoxidil and spironolactone first, and then they usually work quite well. They're more considered first line. I would hardly ever need to use finasteride. I guess it can be used if these two haven't worked well, but that would be quite rare, I find.
Yeah, that's good. Thanks. So someone asked, tar treatment, are they possibly carcinogenic, and also are they safe in kids?
I would think that the risk is probably theoretical or very, very low. Like Sebaratnam shampoo, for example, is indicated for children 2 years and above. So I think that would be something you use as long as they kind of fit into that age group.
Okay, thank you. So next question is about folliculitis on the legs. So it keeps coming back and it's being treated with Bactroban, hot washing, linen swabs, and always the swabs have always been negative. So any idea, please? Folliculitis. So
Folliculitis. I think I will try antiseptic washes first, such as benzoyl peroxide wash. It's antiseptic and has unclogging properties. After that, you can do, again, low dose antibiotics such as doxycycline, 50 to 100 milligrams a day. And I found that to be almost always going to be effective.
Okay, so
Can I also add that sometimes you have to consider that folliculitis, particularly on the legs, isn't always infective, and that friction and other things can cause irritation of hair follicles. And so you need to think about general measures as well, and not necessarily always bombard with antibiotics, because a lot of patients have already tried that.
So you're right. Yeah. So it is the occlusion, sweating.
Correct. Yeah. Using emollients on the legs, lots of different causes for it. Yeah.
Yeah. That's true.
And laser hair reduction can be helpful as well, depending on.
okay, next question. Okay, so this is a bit more topical. So someone asked, is eczema and psoriasis connected to the microbiome? Any idea?
I'll answer that one. I don't know. Essentially, look, the microbiome is very popular at the moment, and there's a lot emerging about it. And the microbiome is, very important in terms of a lot of disease processes, allergy, immunity. The issue is we're not quite sure how it works. And a couple of things to say. So one of my patients that I have a chat to, he's a colorectal sort of a gastroenterologist with an interest in the microbiome, and he sort of says, look, there is probably a lot to do with the microbiome, but we don't know how it relates, but it's an emerging thing. And his answer is, look, the important thing is that the simple thing is that he gets people to just make sure that you shop on the edges of the supermarket and avoid all the processed foods in the middle. So you go to the veggie sections and the dairy sections and all those, having healthy foods without preservatives, because that can certainly play around with the gut microbiome. The problem is that our patients take that bit of information and hear microbiome is important, and I don't doubt that. But then they hear that there's these fad diets they get onto, and that taking this probiotic or this thing can fix this because that's going to affect the microbiome. And it's almost a simplistic way of altering the gut microbiome to fix the problems where they don't want to deal with using creams or other things. And so that's the difficulty I have. The other thing to say is that I like to redirect patients to say, well, the skin microbiome is important too, but we don't put a lot of focus on that. And there's a lot to be said about that as well, with the skin microbiome in psoriasis, rosacea, eczema, you name the inflammatory skin condition. We're learning a lot about the skin microbiome, but once again, we're not sure how to address that. And we know about with the gut microbiome that fecal transplants have been doing great things for inflammatory bowel disease, and people are looking at sweat transplants on normal skin. Not that I'm going to dive into that quickly, but whether that can affect skin diseases. So there's a lot to be done, but unfortunately, it's not as simplistic as the gut microbiome directly affecting the disease. Yes, it does, but I don't know how it is, unless someone else has an answer.
Okay. All right, so next one. Any evidence that probiotics in mother or babies reduce atopic dermatitis later?
I'm not sure what the latest Cochrane data on that is. I generally don't recommend probiotics as a routine thing. That's my personal thing. I think it's not quite clear. I have no objection to it. My general approach to things like this, that if it's safe, which a lot of probiotics are thought to be, then it's helpful. But the problem is once again, a lot of it's marketing, and a lot of the studies, from my understanding, a lot of the studies that show some evidence that probiotics are effective in eczema, you can't actually get that bacterial strain. So to market probiotic, it's like saying, oh, is antibiotics helpful for meningitis? Well, yes, it is, but if you take the wrong antibiotic, it's not going to be helpful for meningitis. And so that's the same story with probiotics, that you can't actually access the one that's been studied. And even internationally, they can't get it. So it's almost like, well, you can't get one, but you'll use another one. Is that as good? Well, there's no evidence for it. So I'm not quite certain about that either.
Okay, good. Yeah. So what topical testosterone blockers can we use for hirsutism or androgenic hair loss?
Clascoterone, I think is, yeah, so Winlevi, but that's more marketed for acne. I guess theoretically it might help with those other indications.
Okay, good. Thank you. Are hemangiomas in babies more prevalent in premature babies?
Yes, absolutely. Premature babies, twins, and primates, and girls.
Yeah, okay. So someone made a comment to say that minoxidil may work ineffectively because you only get fluffy, tiny hair regrowth. I'm not sure about that. So any answer to that?
I think for some patients, it does work. It is not as effective as finasteride, but it is safer. So probably use that first. And if it works, then you don't need finasteride. But if it does work, then doesn't work, then you can add in finasteride as a second-line therapy. Or if the patient is really concerned or quite severe, we can start with finasteride first. But it does work for some patients.
Okay. So next one is on rosacea. So does Soolantra for rosacea cause rebound? Or what? And also, what's the preferred treatment of early rosacea?
So Soolantra does not cause rebound because it's not a topical steroid. So remember, it's ivermectin. Ivermectin you'll all be familiar with orally. We use it for strongyloides and all sorts of parasitic infections. And this is just a topical version of that. And it's altering the microbiome, and it's probably having a pretty targeted effect on Demodex within that microbiome adjustment. There's no issue about rebound. Obviously, what we're saying, though, is that the condition is chronic, it will recur. You can use ongoing long-term treatments of these topicals. For mild rosacea, I think you have to be realistic about what you're going to be achieving, because you're not curing the condition. We're really treating the aesthetics of it for most people. And so I would offer them the topical treatments, but I'd ask them to assess in about 6 weeks to see whether they felt it's made enough of a difference to continue, because really we're asking them to continue with this treatment lifelong.
Okay, so someone mentioned that Physohex has a health safety warning. And so what antiseptic soap can we use these days?
I still have recommended Physohex. You can also use Benzac, which is also antiseptic. I'm not sure if other people do know about the warning with Physohex.
Okay.
I still use Physohex. You could also use bleach baths if you wanted to.
Okay, good. So someone mentioned for kids, do they use any biologics in kids for eczema?
Yes, they do. For eczema with severe eczema, we put them on dupilumab, but under 12, because it's not on PBS, they have to come through a hospital, and the hospital then, we applied to the hospital drug committee to pay for the dupilumab, but dupilumab is actually available overseas for kids with severe eczema from 6 months of age. And that's actually, when they're young is when we really need to capture them, because that's when we can really change their disease course and modify their disease and modify the atopic march.
Okay.
And some of the biologics for psoriasis are also available in pediatrics.
That's good. Okay. So someone asked a question about all the potencies of all the steroids. How do you put them starting from hydrocortisone?
Oh, I guess there's a long list of topical steroids, but you can quite easily find tables. I can't list all of them. But in regards to that question, yes, look, there's hydrocortisone, which is sort of seen as the low potency. Then there's, I'm going to use drug names because I'm not going to, it's too late to name the actual proper names, but there's things like Aristocort and Celestome, and there's always generics to all of those, and that's seen as moderately potent. And then there's potent ones such as Advantin and Diprozone and Elicon and Novazone and Eliofrat and Supriad has come onto the market. But just to keep in mind that even with the potency, I personally feel that there's differences, and that makes sense, between different categories. So there are some within that category I see Diprazone a bit more potent than Elicon, which is a bit more potent than Avantin. Then there's the super potent, where there's Zobet, which is clobetasol, that's come onto the market now, and there's Diprazone OV. Just keep in mind that potency is based traditionally on what's called the vasoconstrictor assay. So how they measure potency is by putting the topical steroid on the skin and to measure the degree of vasoconstriction. Now, that's the surrogate marker for how potent it is as a steroid in what we want to use it for. So we're not treating people for its vasoconstricted effect. We're using it for its anti-inflammatory effect. So it's a marker for how it vasoconstricts, and we sort of think that if it vasoconstricts more, it must be more potent. So there's variance in between that, but just to be clear on how potency is measured and categorized.
Okay, good. So next question, the risk of using finasteride, and do you recommend patients stop after a particular time?
Well, I think the main risk we have to warn the patients about is sexual dysfunction, which can be ranging from reduced libido, erectile dysfunction, or premature ejaculation, and that's quoted to be roughly about 1 or 2%. I think traditionally thought to be reversible when you stop, then that's reverse, but some later studies say may not be always reversible. I think some people have recommended stopping after a few years, but then I don't know if that's definite, and there are some people who still elect to be on the medicine long term, and I'm not sure what other people's experiences are with this as well.
Sorry, if I could just add in, I think we also have to mention depression with finasteride. Unfortunately, it's had a lot of media, a lot of social media things, and in part of the consent, we have to mention that to patients. And this is a condition that they're treating for aesthetic reasons. They have to understand the risks, and they're making the decision to proceed, knowing that it may be an indefinite treatment for as long as they want.
Okay, thank you. So someone actually asked, what is the best topical treatment for rosacea? Well, the question said you mentioned is topical, but which particular topical?
So in terms of clinical evidence, Cilantro probably would be the one that has had the most clinical evidence of being effective. So the trials would say that Cilantro works best particularly for papulopustular rosacea, and works faster. So it has more punch in that regard. Some people will say that Rosex may work almost as well for the redness, may not be as well for the papulopustular component. Azelaic acid, it always gets let down because it's not tolerated well, but it's actually not a bad kind of third player in that. But Cilantro is the answer.